Okay, I think we can get started. Good afternoon, everybody. I'm Tyler Manier. I'm Vice President of External Affairs at the New Jersey Healthcare Quality Institute. It's my pleasure to serve as your moderator for today's event. Just a couple of housekeeping items before we begin today's presentation. All of our phone lines are going to be muted for the duration of the program to limit background noise. You may ask questions at the conclusion of our panel presentation by typing into the chat box. If you'd like us to unmute your line, please raise your hand by using the webinar controls. And just know that today's webinar is being recorded, and we will post a copy of it to our website, www.njhcqi, later on this afternoon. And so for today's topic, bringing patients back to care, how to re-engage and care for patients as the COVID-19 pandemic continues. Getting people to focus on preventive and chronic care needs is really important. Unfortunately, 4 in 10 adults reported avoiding medical care due to concerns related to COVID-19, which can result in increased morbidity and mortality associated with both chronic and acute healthcare conditions. Our multi-stakeholder panel today is going to share new and innovative strategies that they're using to help navigate how to provide safe and quality care to patients during a pandemic. At this time, I'd like to ask each of our speakers to briefly introduce themselves and tell us why they're here to speak on this topic. So please say your name, your title, organization, and why you're here to talk about the specific patient population that you work with. Jennifer, can you kick us off here?
Hi, sure. Good afternoon, everyone. I'm Jennifer Houston. I'm the Director of Healthcare Clinical Transformation at Lifeline Medical Associates. We work in women's health, OBGYN, and certainly the pandemic made us have a very quick solution as to how do we continue to see our patients. Our pregnant patients need to continue to have their care. So definitely created protocols and visit schedules very quickly to provide safe, quality care for our patients, and would love to talk about that today.
Thanks, Jennifer. Dr. Koffman.
Thank you. Dr. Harvey Koffman, Senior Medical Director at Quest Diagnostics. I've served in a wide variety of roles in my 29 plus years at Quest Diagnostics, including as the first Chief Laboratory Officer. I lived in New Jersey for a while, now a resident of Massachusetts. Quest Diagnostics is headquartered in Secaucus, New Jersey. We have the largest, most sophisticated laboratory in the country in Clifton, New Jersey. It's an amazing automated laboratory. Quest Diagnostics processes 150 million test requests each year, generates several billion test results each year. And given that approximately 70% of healthcare decisions involve a laboratory test, we have a window in terms of health trends, and based on our size, we've got a pretty big window. Thank you.
Thank you. And Quest is one of our newer Quality Institute members, so welcome. Nikki.
Hi, everyone. I am a medical accounts director with Novo Nordisk on the medical team. And really, I'm excited to be here because we know from the pandemic, what it's showed us is that chronic illnesses like diabetes and obesity are part of the top 5 illnesses that led to severe COVID. And at Novo Nordisk, as part of my role, is focusing on education and awareness around chronic diseases. And when we are able to treat and increase awareness around these diseases and have people more aware of their health, we're ultimately going to be able to prevent or decrease the likelihood that many people suffer in the long term with complications. Specifically talking about obesity, there is over 125 million people in the US living with obesity. And in New Jersey, it's about 28% of the population, but not a lot of specialists treating obesity. And so it really will take a village, and policymakers, providers, families, communities, and we really all need to work together. From the Novo Nordisk perspective, part of our role is really working with patients and getting patients to advocate for their care. There are a lot of stigmas and biases preventing them from seeking out care. We also work with providers in training, educating on obesity treatments, diabetes treatments, and guidelines. We're also working with health systems and employers, as well as state and federal policymakers to allow more access and equitable access for therapy. So look forward to discussing that today.
Great. Thanks, Nikki. Jean?
Yes, hi, I'm Gina Reyes. I am the Director for Clinical Transformation and Quality at Horizon Blue Cross Blue Shield of New Jersey. I have been with Horizon for about 4.5 years. I have spent my entire career in the healthcare space as a registered nurse in various leadership positions and population health roles. I lead a team of nurses and social workers and business-oriented team members, and we work with value-based providers. I am pleased to be here with the other panelists, as well as all of you, to discuss this very important topic of re-engaging patients in primary care. This is definitely a high priority topic for Horizon and our network providers. And while we understand and respect patients' feelings, we also need to take steps to restore their confidence in our healthcare. Overcoming deferred routine care and delayed chronic visits is critical in improving outcomes, especially catching illness at its early stages, which has the best prognosis. So, while more people are getting vaccinated and life is slowly returning to the new normal, many people now are feeling the stress and anxiety of figuring out how to re-enter public life after living in isolation during the pandemic. So I want to thank Quality Insights for your leadership in bringing this topic to light. So thank you.
Great, thanks so much. Ellery?
Good afternoon. My name is Ellery Tarifi, and I'm a nurse practitioner at Care Plus New Jersey. I provide psychiatric treatment and medication management for our clients suffering from mental illness and substance use disorders. According to the National Institutes of Drug Abuse, otherwise known as NIDA, more people died from a drug overdose in the United States in 2020 than any other one-year period in history. That's more than 93,000 people that died in 2020, which was a 30% increase from the previous year in 2019. I'm here today to advocate for these clients. Opiate use disorder is a manageable illness. We have medications that can save lives, decrease overdoses, and stop unnecessary deaths. By coming together today, hopefully we can think outside of the box, open up the discussions on how to remove these barriers, and thereby provide opportunities for these clients to have a potential for a positive and productive future.
Thank you. Thank you all for being here. We really appreciate it and are looking forward to the discussion. So I'm going to kick things off with a couple of questions of my own, but folks in the audience, please type any questions that you might have into the chat box, and we'll make sure that we get to as many as we can. So to kick things off, Nikki, I'm going to ask you first, how is Novo Nordisk working with employers to encourage employee health and wellness during this time?
Thanks, Tyla. And I know, this is an important topic because we do have some employers on the line, and employers provide healthcare for over 60% of the population. And health and wellness is really becoming more of a priority, especially in light of COVID. When we think about health and wellness, we really would like to improve our employees' overall well-being, including mental, physical health as well, right? So if we think about obesity, we don't often think about obesity or weight management as a top priority, but it is actually becoming more of an importance because, as Jean mentioned, we're thinking now more about prevention. And so we're talking to a lot of employers around different initiatives that they can take in reducing the costs and comorbidities related to weight. And as an organization, Novo Nordisk, we do recognize that it is challenging in the workplace. It's sort of been a taboo topic, but we are really working with employers to understand that it's of value, it's cost effective. There is a return on investment in putting strategies in place around chronic weight management in the workplace. We also are providing resources to help employers improve, monitor, maintain employee health and wellness. And this could be short-term improvements and long-term improvements. So we have some employers that in the short term are looking at identifying high-risk individuals and putting specific programs in place for high-risk employees. And in the long term, you may think about putting together more long-term programs like employee weight management programs and services. Recently, we partnered with an organization called MECOM. It's a corporate medical director organization, essentially, in the Northeast. And the program, it was actually yesterday, and they shared how important medical directors and employers are in creating a culture of health and wellness, making the healthy choice the easy choice. So I thought that was important. And then some other unique strategies that I've seen working with employers. You could also, I have an employer that's really focusing on diversity and inclusion. That's a pretty big topic and priority for a lot of organizations now. And they formed a weight and wellness employee resource group. And that's really in line of the vision of having an inclusive culture of wellness and decreasing the stigma around weight or obesity in the workplace. Obesity has actually been the number one cause of stigma behind, number one cause of bias behind racial bias. So it is something that is important. We're also working with employers to educate around chronic diseases. As we mentioned, people have deferred care during the pandemic. So we're doing education around biometric screening results, around World Diabetes Day in November, Heart Health Month, and even healthy cooking demonstrations by celebrity chefs. So those are just some ways, I guess, like in short term. We also have employers that are really taking the next step and implementing weight management programs and looking at clinical outcomes for their employees. And then finally, we also have some employers that may not have certain benefits for weight management therapies. And some don't even realize that they have to opt into coverage for weight management therapies. And it's not always covered as a standard benefit. Lifestyle is usually covered, but we know it works 1 out of 10 times in the long term, and it's challenging. There's biological reasons that many people don't understand. So, we know that in terms of accessing therapy, less than 2% of people actually receive pharmacotherapy or bariatric surgery out of those that are eligible for the treatments. So we're really trying to work with employers to create a patient journey that's easy, accessible, inclusive of all options. So just to, give you some ideas of how we've been working with employers.
That's great. Thank you. And I know we're going to talk a little bit more about technology tools later on in the program, but maybe I'm preempting this a little bit, but has it been even more challenging working with for employers to work with their employees when a lot of the workforce is working from home still during the pandemic?
Yeah, and this is been a big topic as well, because I think we have different strategies in the virtual workplace. There's some really great tools out there and ideas and examples that maybe we can share post-event on how some employers have pivoted, making the healthy choice the easy choice. Because I know in person, you can maybe make the salad bar right front and center. You can make ergonomic workspaces, but in the virtual space, I know some employers are allowing for at-home ergonomic technologies to make it easier, having walking meetings, for example, instead of us, we're sitting in front of a computer, so we're not really walking the talk, but there is a lot that we could do from like the leadership standpoint to encourage healthy living. I think a lot of it comes down from the leadership, but yes, we have to pivot.
That's a great point. I mean, just personally, our staff at the Quality Institute, I know we will take things offline and do, old school conference calls and walk while we're talking sometimes. And we share, ideas and suggestions for different workout videos and things like that we can do at home. So even the little stuff helps.
Definitely.
Thank you so much, Nikki. So Ellery, how has Care Plus used telehealth as a tool to maintain care for your addiction recovery services? And what challenges does that present for you in terms of prescribing to your patients?
So COVID has presented us with many obstacles, but telehealth was one of the more positive things to come out of COVID. Telehealth provides clients with the opportunity to seek care, which may have been otherwise difficult to obtain. Clients that suffer from extreme anxiety, lack transportation, have limited finances, or even disabling medical conditions can now have the opportunity to be evaluated through telehealth. From my own personal experience, I've witnessed an increase in the number of clients seeking treatment for opiate use disorders, specifically during COVID. I was told that some of the inpatient facility treatment centers were limiting occupancy due to lack of staff, social distancing, and overall fear of COVID. I've even heard of hospital floors that had many of their detox and substance use beds changed over to COVID beds. As a result, many clients seeking treatment for opiate use disorders were therefore referred to Care Plus. By having the ability to see these clients while they were in the comfort of their own homes, I was able to start the Suboxone induction process and essentially follow up with them on a daily basis to monitor their progress. Although the use of telehealth can be advantageous, there are some drawbacks and some limitations. Some clients may not have access to a computer or a smartphone. Depending on their location, the signal strength may not be that good. And other limitations are, of course, distractions from clients' family, children, or other pets in the background. With these limitations, it is harder to build a rapport with the client, as I may not have 100% of their attention. And in psychiatry, much of the communication comes from body language and facial expressions. And depending on the quality of the camera or the strength of the signal, sometimes it is hard to read someone's body language, see their face, or assess if they're experiencing any medication side effects. So again, Care Plus has adapted to the telehealth model. It has greatly benefited our clients. And as we continue to deal with the COVID and the emerging strains, telehealth will prove to be beneficial in supporting our clients that suffer from mental illness and substance use. In my opinion, telehealth is not the new way of seeing clients, but instead is an option that when used with face-to-face visits can improve compliance and outcomes.
Great. So Ellery, you've had to make a lot of choices, I'm guessing, about when it's appropriate for your patients to use telehealth versus when they need to come into the office for an in-person visit during this time.
Yeah, it's fortunately a lot of the prescribing regulations were relaxed, like the Ryan-Hart Act, which says that you have to see someone face to face before you could prescribe a controlled substance. I mean, that was relaxed. So with that off the table, I mean, we were able to really get a lot of patients onto Suboxone maintenance. And now that some of the the numbers they were going down, and who knows if they're going up. But patients are coming back into the office. And again, if we see them, throughout the year mixed in again with some telehealth visits, it's a good hybrid model.
Great. Yeah, and you mentioned some of the difficulties that can still present themselves in using telehealth. I'll just make a quick plug. We had a conference in May where we talked about the digital divide. There's still a lot of obstacles for people that you mentioned in terms of being able to, use smartphones, whether they're comfortable using them or really understand the technology, people who don't have great broadband access. So certainly after this program, we'll be sure to send out the recording from that conference in May, because we had a lot of great discussion around different strategies that we can use and things that we should be thinking about for the future in terms of bridging that digital divide.
Yeah, definitely. It definitely poses a problem. When everything works, it's great. And then when it doesn't, it just becomes a nightmare, because now you're trying to call someone and then their phone isn't taking the phone call because they're on the telehealth app. So you have to sort of kick them off. Yeah. So, I mean, there's a lot of work throughs that you have to figure out, but when it works, it's great.
Yeah, great. Thanks, Ellery. Dr. Koffman, have you seen a return to pre-pandemic testing rates, and what implications does testing have for the acuity of chronic diseases, cancer, et cetera? If you could talk to us about that.
Sure. Thank you, Tyler, and everyone here. So as a leader of Quest Diagnostics health trends for the past 15 years, we published and put out a lot of data on COVID-19 and the pandemic, and surveys on people's insights and perceptions. Now, I've had quite a number of publications. The pandemic's been good for me in terms of publications and such. I've done a lot of interviews. I did a recent interview for NPR. For those interested, it's Tech Nation episode 21-33. But let me start off with some of the survey data that we did with the Harris poll late last year. We looked at over 2,000 American adults, and over 1/3 of Americans said they did not plan to resume attending in-person medical treatments or appointments until the pandemic was under better control. 1 in 2 Americans, 51%, said that only a severe illness or injury would motivate them to seek in-person medical care during the pandemic. And more women were impacted than men in a negative way. So in terms of mental health, it was 49% for women, 36% for men, financially 42% for women, 37% for men. And for physical health, it was 33% for women and 26% for men. We also looked at differences based on race and ethnicity, and it definitely impacted minorities more so than for whites. The lack of preventative care is going to fuel concern about many undiagnosed conditions, as we've discussed so far. 1 in 2 Black non-Hispanic Americans are concerned that they currently had a undiagnosed health condition compared to 39% of whites. These are people who said that they have an undiagnosed health condition. And 60% of Americans said that they had delayed or skipped care during the pandemic. And again, it was more heavily weighted towards Black and than white or Hispanics. We've had a number of publications, and hopefully on the screen you can see, if I can go to the larger format. A recent publication, August 31st, in JAMA Network Open, that looked at gaps in care. We've looked at gaps in care for chlamydia and gonorrhea, hepatitis C testing and treatment, diabetes, and some other areas. This one's on cancer, got a lot of good play. In the early months of the pandemic, we saw a 30% decline in patients in terms of diagnoses of cancer. It dipped to only 10% below baseline, being 2019 in the mid-period. And then if we look at the late period of November of 2020 through March 2021, it was down 19%. So these are dramatic declines in cancer diagnoses. This data is for New Jersey only. You can see from the blue, orange, and black lines that Quest Diagnostics testing volume is increasing. Thank you, United Healthcare and Horizon Blue Cross Blue Shield, when we join those contracts. But the big giant red triangle there is the gap in care. These are men who just, some showed up later, but other men, didn't show up. So net, we're missing that big giant red triangle, which is approximately 16% or so of an annual population. So we've dug deeper, and these are men who are typically younger and at earlier stages of disease. When they do present, they're going to present at a later stage. Some of them at a later stage require more aggressive therapy and have a worse outcome. And then here's just one more, looking at New Jersey data only. The light blue bars are 2019, the dark blue bars are 2020. You can see what happened in the early months of the pandemic. It never returns back to baseline. So what happened is that these younger women who are more likely to get tested for chlamydia and gonorrhea, just aren't yet re-engaged. This is going to be our lasting legacy that's going to play out for a number of years of patients who just haven't shown up for care or are showing up late, and we're going to suffer in terms of the cost, in terms of therapies, and the cost in terms of lives.
Yeah. So essentially, if these trends continue, we're really not going to be able to see a lot of those patients, not diagnose them properly, and their acuity will rise in terms of the level of care that they need.
Yeah.
Thank you for that information. Gina, how is Horizon working with your members and your providers to educate and encourage vaccine adherence?
Sure. So I mean, there's no doubt that the COVID-19 pandemic has reshaped how we live our lives, everywhere from where we work to where we're going to school, to the people who we surround ourselves with. And, COVID has brought upon us these new challenges that have affected us all. And one of the biggest hurdles that this has brought upon is the amount of misinformation that's circulating out on social media. So, Horizon has been focused on ramping up our communications and outreach to the communities that we serve, which is largely focused on steering our members towards outreaching their providers to have these conversations to seek medical care, really trying to leverage that provider-patient relationship so that, and having these conversations that are specific to the circumstances that member's in. Dealing with. We've been doing this through multiple communication channels, which include, and using pretty much all available means. We're doing this through digital technology, which I can talk more about later. I know that's an open panel discussion question. We use newsletters. We message this on our websites. The key is communication and using various methods to accommodate everyone's learning styles. There may be people that are comfortable with printed material and others comfortable with digital technology. So really communication is the key, and really trying to steer members to reach out to their providers to have these conversations and to seek medical advice. In terms of how Horizon has been working with our providers is in overcoming vaccine hesitancy, has been largely through sharing of best practices, such as motivational interviewing techniques. My team has taught motivational interviewing techniques for several years now, so it's not something new that we started as a result of the pandemic. However, we've since incorporated tools and resources from professional organizations and government agencies that we disseminate either during our trainings, or we share this through our monthly value-based newsletter. We actually have a COVID corner, which we've dedicated in providing tips and tricks that we've learned from either discussing best practices with other providers, on other webinars and conferences. So as we learn new information, especially, what Ellery was talking about with the telehealth, there is a proper etiquette in preparing for a telehealth visit so that you can get the most out of that visit, so you don't have disruptions and concerns. We've been sharing those tips and tricks, not just with members that are calling in for telehealth, but also with providers, and making sure, they're designating a space in an area so that they, so that they're minimizing disruptions on their end as well. And also keeping member experience at the top of, a focus with telehealth. I think that's definitely a new area where we're starting to see, as a result of telehealth, that's an opportunity that, we can work on to improve member experience overall. But we've also have teamed up with other organizations such as Merck, and we provided a vaccine hesitancy webinar with one of their clinical leaders, which we provided to all of our network providers. So it's largely around best practice, sharing of best practices and communication. That has definitely been the key, and using all available communication channels so that it accommodates everyone and you can outreach as far as possible.
That's great, Gina. Thank you. And in terms of the resources that you mentioned, if there's any that are publicly available that you'd like to share with our audience members, I'm sure there are a lot of folks that would love to see, just in terms of best practices and communication suggestions. That would be great.
Sure, absolutely.
Great, thanks so much. Jennifer, last but not least, how did Lifeline rethink the historical schedule of prenatal care visits, which, as I understand it, was very long-standing, to provide more flexibility to your pregnant patients during the pandemic? How did you pivot?
Sure, Tyler, thank you. So prenatal care has been delivered the same way since a prenatal cadence of visits has been established back in the 1930s, with the Children's Bureau proposing a 12 to 14 in-person visits, and then additionally then any other touch point with ultrasounds, et cetera. And although we know that that there is benefit to our maternal outcome and neonatal outcomes with having screenings and counseling and interventions during their antenatal visits, it's not so clear how many the right amount of visits are. So the COVID-19 pandemic forced us into having to rapidly evolve and change how we practice. At Lifeline Medical Associates, we deliver over 10,000 babies per year. So we had a lot of patients, especially back at the beginning of the pandemic, that needed to continue to be seen. And with our Chief Medical Officer, Dr. Rona Magrill, quickly came up with a plan of how do we get our patients taken care of and have them get the right care at the right time. This actually came in line with some projects that we were working at Lifeline with what we call 21st century care, which is providing the right care for our patient and right sizing prenatal care for our patients. So the timing really was perfect to have to roll this out very quickly. In 1 week's time, we had looked into what other recommendations there were, what were our governing agents, ACOG, SMFM, putting out there to propose for visits, and established a cadence of visits, a hybrid schedule where some visits needed to be in person. You needed to, put hands on that patient, do your assessment, whether the patient needed an ultrasound, et cetera. But other visits can be accomplished virtually via telehealth. And really what this did is involve our patients in their care. They became active participants in their care when they're home, needing to weigh themselves, take their blood pressure, and really get them engaged in their care. That was definitely, I hate to say it, almost what we needed to really get this change of prenatal care visits and the cadence to where it should be. As we move forward, we'll be able to get more evidence to see what visits can be eliminated, what can be in person, or what needs to be in person, what can be hybrid, and at the same time, keeping our patients engaged with the support that they need throughout their care.
Right. Yeah, and I know it's obviously a really new and challenging time for newly pregnant patients. So after, when we share some new resources, we'll also share some resources that we created at the Quality Institute with the New Jersey Department of Health for pregnant patients and how they interact with their physicians now during the pandemic, and some things to look out for. So we'll make sure to share those as well. So at this time, we're gonna ask the whole panel some questions, and for our audience members, please chime in, ask some questions through the chat box if you have them, and we'll make sure we get to as many as we can before the program's over today. So any of you, please feel free to chime in. I'll certainly call on you as well. One of the questions I had was, many folks are not seeking care due to stigma. We mentioned it earlier. I think, Nikki, you mentioned it. There's stigma associated with mental illness, substance abuse, obesity, many different disease states. And I'd like some of you to share the strategies that you're using to reduce stigma among patients so that's not a barrier to them seeking out care. Nikki, I'm gonna call on you first.
Sure. Yeah, and I'm going to share my screen on this as well. I think, we talked about earlier, stigma does prevent people from seeking care. And even as healthcare stakeholders, all of us, we can do a better job in engaging patients. You can see here that, there are some strategies to mitigate the weight bias, but essentially why this is important is because weight bias is the most common form of bias in the US, followed by racial bias. And I think one of the biggest failures we've had in this country, but also around the world, is that we've been focusing on two causes of obesity, and that is diet and exercise. But it is much more complex than that. And that includes your genetics, your biology, your social determinants of health. It's not really a character flaw, and that's what had been perceived in the past, that it's a character issue, but it's not a character issue. It is about your chemistry. So some of the strategies that I can share and may apply to other disease states as well is really raising awareness and changing the language about how we talk about people with obesity. And if we can change the language, stop using words like fat, obese, morbid, because that language, now those words really can deter people from seeking out care. And if we can reduce the stigma, more people may be willing to seek out help. And as healthcare professionals, we can be in better position to provide care for people. From a patient perspective, we have resources that can help patients and employees prepare for better conversations and more productive conversations with their healthcare provider around weight. Sometimes we don't know how to bring it up. We've never had these discussions and it could be awkward, right? And then from a healthcare provider perspective, I think one of the main issues is that we're just not educated. We have not been traditionally trained on obesity. And recently a paper looked at obesity medical education in schools throughout the entire world. And what was found is that nowhere in the world, no level of education is doing a good job on educating about obesity. So specifically here in New Jersey, we have been working with medical schools and training programs to have dedicated curriculum on obesity. So with Hackensack, with the Rutgers Pharmacy School, we are doing some obesity education to incorporate that into the training for providers. But beyond this, we're also working with New Jersey healthcare systems on updating weight management strategies and looking at it from a population health lens, a prevention lens. So some of the systems are now working on employee initiatives, working on creating provider referral programs, so it's easy for patients to navigate through the system, educating providers on disease state as well as stigma and bias, and ultimately looking at the impact on these programs for, from leadership perspective. Specifically, I can share one of the health systems in Jersey, Robert Wood Johnson, has taken a pretty proactive approach, and they've piloted a successful employee weight management program. And one of the interventions is they're really doing a lot of outreach, telephonic outreach to individuals, and they also have a team of dietitians, exercise physiologists, providers that are passionate about this and passionate about prevention. So we're really excited about the work they're doing. But from a policy perspective, I did want to mention that there is, because of the historical stigma and bias, that obesity has more to do with lifestyle, there is outdated policies. So under current outdated law, Medicare is prohibited from providing some of this evidence-based care, and only 3 state Medicaids, including Delaware, cover anti-obesity therapy. So we are also working on policy improvements on the state and federal level. There is a bill called the Treat and Reduce Obesity Act, which is a bipartisan bill, and the goal is to improve the care and access to treatment for obesity. And so ultimately, having support for this will improve some of the health inequities in care, and we'll have more patients and providers advocate for this. So really, to answer your question, there are stigmas and biases, but there is a lot more we can do, and I think we all need to be open to having this conversation.
Great. Thanks, Nikki. Dr. Koffman, you raised your hand.
Yeah, Nikki, I'm going to push back a little as a physician. Physicians, in terms of the limited number of minutes to spend with a patient, typically don't do a good job dealing with, I'll call them social issues, whether it's smoking or weight. They're just not good at engaging on those histories of sexual activity, physical activity, diet, and such. And just, honestly, I think it's a struggle in terms of trying to engage doctors directly to address it versus making referral to others who are maybe better positioned to deal with the complex issues to get people on the right track.
Yeah, and I definitely hear that. It's challenging in the primary care space or provider space to spend that time because you're dealing with, or you're trying to manage other complex comorbidities. So a lot of the health system, I think, are really trying to provide that support to the providers now, and create those referral pathways and make it easy for providers to refer to obesity specialists or dietitians or nutritionists or exercise physiologists, because it really does take a village, and it can't just be on the primary care providers. So I totally understand, what you're saying, and I think the systems are really recognizing that to provide more resources.
Thank you both. Ellery, did you have anything that you wanted to add to this conversation?
Yeah, speaking about the stigma of mental illness and substance abuse from a prescriber standpoint, I try to normalize what my clients are experiencing. I approach mental illness and substance abuse in an objective, non-judgmental manner. And of course, what I try to do is I compare their mental illness with common medical problems such as hypertension, dyslipidemia, and diabetes. I often ask my clients, well, what's the difference between a medical condition and mental illness or substance use? And I think once patients understand that these are treatable, manageable conditions, they become more comfortable with the idea of having, a diagnosis of depression or anxiety or bipolar, and are willing to understand how to better manage their concerns. In terms of substance use, I encourage clients to be as open with me as possible. I don't threaten clients with the idea of discharging them from the practice if they relapse. I don't yell at them, and I don't minimize any of their stresses or triggers. Instead, I try to focus on building the rapport and the trust between myself and my clients. By having this type of relationship, better communication can be established, thereby allowing my clients to have a better understanding of what it is that they are dealing with and how to better cope with it. Again, trying to destigmatize mental illness and substance use is a big challenge. But as we slowly, break down these barriers, we open up the doors to those who are looking for help but are reluctant to seek it.
Thank you. Seems like such simple concepts. I mean, just changing the way that we're talking about things and making people feel more comfortable seems like it could make a huge difference. Great. So one other question from me, and I think we're starting to get some audience questions, which is great. So I want to get to those. For me, are you all using any technology tools such as apps to keep your patients engaged in their care? I mean, we talked about some of the barriers in technology use, but for those patients that are equipped with smartphones and they do have the ability to use them, are there any innovative ways that you're using them to, better engage your patients, and are you seeing them working? I'll just open that up and see who wants to chime in there.
I can definitely add into this. So going back to having to get our patients in via telehealth and hybrid visits, et cetera. At that point in time, like I said, we were already working on some innovative ideas here at Lifeline to better engage our patients. And currently we're actually working with a patient engagement app. We're doing a pilot with Wildflower, which is a patient engagement app that that the patient can use throughout their pregnancy. And it provides education and the ability to have some remote monitoring, Bluetooth weight, a scale, blood pressure. They're provided with a Doppler, and on their cadence of visits, those virtual visits, the patient will use the remote monitoring devices, but throughout the pregnancy, they have this app readily available that follows them per week of gestation, so that they're provided with education. They have articles on all kinds of things. Early in the pregnancy, our patients need a lot of support. There's genetic screening and a lot of testing that they need to have done. And there's a lot of questions and uncertainties at the beginning of pregnancy. So they have this right at their fingertips, and they also have the ability to mark their questions for their provider and engage with their provider very regularly, so that they can know the questions to ask and we like to think of it as right-sizing prenatal care. What is the right care for this patient and what is the right care for another patient? With the engagement app, when they have virtual visits, say, you have a multip who has other children at home, that the technology has helped provide the care for our patients in the way that they need it. And hopefully with this pilot, we'll be able to move forward and really improve our care for our patients.
Great. And that particular app is specific to pregnant patients, Jennifer?
Yes, it's for pregnant patients and postpartum, and does have other, it extends into pediatrics too.
Okay, great. Thank you. Anybody else want to chime in on this one? Dr. Koffman?
Yeah, I will. Thanks, Tala. So in terms of technology, there's Ellery did a great job in terms of mentioning some of the issues, but I'll also add to that list, which is issues with language, health literacy, and as we think about the various barriers that Ellery mentioned in terms of the technology itself, these are really affect minority populations more than non-minority populations, and we need to address these social issues that will then permit broad application across the spectrum of patients. It's more urgent than ever because, as we've discussed earlier, there's this gap in care, and so there's a demand side, but then there's a supply side. And the supply side is that the number of doctors and nurses and dentists and ophthalmologists hasn't changed, or it's even gone down a bit, but the demand is even higher. And so we've got this mismatch where people just can't get appointments, or the appointments are months in advance, longer than it used to be. And so the only solution is to go ahead and engage allied health professionals in new ways, the telemedicine, any other app or tool that can facilitate handling the tsunami of new patients that we need to address in the months and years ahead.
Absolutely. Nikki, you had your hand raised.
Yeah, in terms of other technology tools, we as an organization do offer virtual support tools to engage patients in lifestyle programs, and we also offer health coaches. Specifically online, we have some patient and provider resources. One is truthaboutweight.com to educate and motivate patients on taking the next step. And then for providers, there's a site called Rethinkobesity.com, and that will provide some information on how to have conversations. And we can, you can also provide this to patients on having conversations around that and taking the next step. And then recently we have partnered with CVS Health on a pretty comprehensive nutrition coaching program. And it includes a digital app with shopping lists, recipes, restaurants. You can message a dietitian. It has coaching sessions on there. So we are partnering with a number of different organizations, vendors, and technologies, because we know that it's not really a one size fits all. And as Jean mentioned, different options work for different individuals, right? So there's some ideas there.
Thank you. Yeah, we'll be sure to share those websites after the webinar as well. Jean.
Yes, I just wanted to mention on what we're doing at Horizon. We've actually been working on expanding our digital technology for quite some time, and the pandemic really kind of sped things up, and we were able to get some things off the ground. One in particular, we do have the Horizon Blue app, which many of you may be familiar with. You use it to display your digital ID. You can use it to check claims, but there's also sections there where you can use it to connect to a nurse if you have a question, so like a nurse chat function. And there's also, we have partnered with Amwell in providing telehealth visits. So it's, I'll just preface it by saying it does not replace a visit with the provider. However, it is offered as an added convenience to members. So if you need a visit right away, you don't have time to wait for an appointment, you want to connect with a telehealth doctor at that moment in time, that's, we have that available. We've also partnered with a WebMD called My Health Manager, which members have access to their online personal health record, which it automatically captures diagnoses, medicines, lab results from healthcare professionals. And, members can also use it to self-report additional information to create a comprehensive record. And they can use this, especially when they have to talk about medical history to a new provider. So we have that available, as well as personal health assistance. Personal health assistants can assist in explaining benefits, in connecting a member with a care manager, case management, also figuring out if the care you need is covered, and helping to find a doctor. As well as, we have been involved in Neighbors in Health within our community, a program which we've partnered with NowPow to address the social determinants of health, some of the food insecurities, transportation issues, things of that nature. So, we are continuously working on expanding that digital footprint, but I think overall the key takeaway is the more you can engage the patient, the better chances of them, staying engaged. So finding ways to involve patients in shared decision-making and taking an active role in their care is really the best practice in trying to re-engage them overall.
That's great. Thank you. And Dr. Koffman, I think you put it well, just in terms of, having greater access to other professionals and opening these different lines of communication to make sure that we're meeting people where they are is really where we're going to find greater access and greater engagement. I'm actually going to ask an audience question before I get to my final question, because I want to make sure we get to them. We had one come in on the chat box here, and this is for anybody to answer. Are there particular types of care that are being avoided more than other types? And in particular, advanced care planning, decisions, counseling, conversations like that. Is anybody noticing that particular types of care are being avoided more than others?
I'll jump in. So in looking at the Quest Diagnostics data, the one area that is definitely not impacted is pregnancies. We anticipate that last year there was about a 4% decline in pregnancies. This year we anticipate 1.7%. We know that because we have to test early in pregnancy so we can track it out for many months subsequently. That 1.7% decline nationally is identical to what it was in 2017, 18, and 19. Pre-pandemic, or 18, 19, 20. So pregnancy is unaffected. One of the biggest areas impacted is substance use disorder. We've seen a dramatic decline in testing in that particular area. We also seen more dramatic declines in younger individuals and, quote, healthier individuals avoiding skipping care than those who are, let's say, symptomatic and older, who are historically more engaged with the healthcare system.
So you think, Dr. Koffman, it's more likely that folks that don't have connections to, a primary care practice or, are staying involved in their healthcare are more likely to skip regular treatment?
And who are asymptomatic, and recognize, particularly for chlamydia and gonorrhea, a lot of the infections are asymptomatic for quite a while, and they can cause long-term consequences in terms of infertility and pelvic inflammatory disease and other serious conditions.
Anybody else want to chime in on this?
Yeah, hi, I'll chime in. We are definitely seeing in particular, diabetes. We're seeing more gaps in care for the diabetic population. That has definitely been notable on our end in terms of, we track our quality rates, and we've noticed just a larger gap in closing those gaps in care for diabetic patients. And really the struggle has been re-engaging those patients back into the office. I guess, as Dr. Koffman said, if, they're asymptomatic, they're sort of, just kind of, watching what they're eating, doing the best that they can. Meanwhile, they have A1Cs that are like, really high. Until it becomes so severe and they're symptomatic, that's when they seem to seek care. And then also there's a large population of pre-diabetes out there. So with the pandemic and the government shutdown, and, people have been, gaining more weight and being less active, that is definitely one that we anticipate to really be impacted by in terms of long term. So as those patients start to come back into the office, and, when they've moved from being a pre-diabetic stage to now diabetic, that is definitely a concern. And, just the one part of the question about advanced care planning decisions and counseling, I have not heard of anything particular during our conversations with providers, but just as a clinician myself, that it's a very difficult conversation to have in person. And so I can't even imagine, the difficulty it is to have that conversation, over a telemedicine or a telephone call. So, yeah. But that's a great question.
Yeah, and we've had our, the Quality Institute, we have a program called Conversation of Your Life, where we have task forces in 15 different counties across the state that create programming for folks to have that conversation in a more comfortable setting and make it, easier for them to go back to their families and then eventually their provider and document those wishes. So we'll definitely share those resources as well, and make sure that folks know that that programming is available. Did anybody else want to weigh in on a particular question? I think we had one more from the audience I wanted to get to. Is the change in telehealth to in-person impacting the decrease in certain types of testing, such as STDs? Anybody want to take that?
Yeah, I'm not sure we have the answer to the specific question in terms of the impact of telemedicine directly on things like STDs, but it clearly becomes challenging to do a physical exam remotely. One can look at skin rashes and such, but to do other types of exams, you got to do it in person.
Right. So that really becomes, I think, the point where the provider makes that decision call, right? Whether it's, maintains a telehealth visit or whether it's required to be in person for diagnostic testing, things like that.
And getting the right mix, as Jennifer mentioned, you gotta and personalize it. Sometimes you can sort of quote trust the patient, and other times you need to bring them in.
Right, not a one size fits all situation by any means. We have about 2 minutes left, so just want to make sure if anybody else has any other questions, they have an opportunity to ask. And like I said, we'll certainly send some resources out after the fact as well. I do have one last question that we'll certainly get to if we have a minute. Staff turnover, obviously that has been a huge issue, and our clinicians that are out there on the front lines are facing a lot, and there's a lot of burnout. So staff turnover or loss of workforce, how has that affected access to care in your mind?
Yeah, I'll jump in. So we haven't had a detriment in laboratory services provision in New Jersey due to the pandemic, but we are struggling to fill a lot of positions. And in some cases, we have to increase bonuses. We're seeing more people not show up for interviews, not show up for their first day of work. More people giving counter offers. We're working on sign-on bonuses and job fairs and geo-targeted ads and job postings, as well as more targeted addressing compensation where we need to.
Thank you. Jean, did you want to weigh in?
Yeah, just really quickly, this has been a topic that we've heard across the entire state, regardless if the practices are in the north, south. Definitely an area where they're seeing a decrease in staff, and it's getting more and more difficult to backfill those positions. And when they do backfill them, they're seeing a competency gap, like an experience gap. So there's a lot more newer staff and there's a lot fewer experienced staff. So they're having to be really creative in trying to maximize everyone's to work to the top of their license and cross-train people so they can accommodate, to account for that gap in experience. But, we're hearing that medical assistant schools are closing. So that has had a big impact on some of the practices. So definitely a concern, not just in the hospital setting, but in, the primary care space, as well as just ambulatory care overall.
Great. Thank you. Yeah, definitely an issue that we're looking at the Quality Institute and we'll be working on in the months and years to come. Thank you all so much. We're at about time. So thank you so much for all of your insights. I think this was really helpful. And for all the folks that are on the line, thank you for joining us. We will share some really helpful resources after the fact, and hope that everybody has a great day. Thank you all for joining us.